Okay, so today we're going to talk about home sleep apnea testing or HSAT rules for adults. As of right now, there are no HSAT rules for children in the manual, so I'm guessing that there are no, that we don't do HSAT, aka portable monitoring on children. All right, so let's get straight into it. So, what is HSAT? HSAT is home sleep apnea testing. However, an HSAT study does not necessarily have to be done at the patient's home. These tests can be done in a sleep facility or elsewhere. Okay, so basically it can be done pretty much anywhere, anywhere the patient can sleep. HSAT is also referred to as unattended portable monitoring. Some people just call it portable monitoring or PM, or it can also be called OCST, which is out of center testing. So HSAT, portable monitoring, out of center testing, home sleep study, all of those terms are interchangeable. They mean the same thing. All right, now let's watch this video. All right, that video was just basically showing us a little bit about home sleep testing or HSAT. All right, so why is HSAT imperative? Imperative meaning important. Why is it important? Besides the fact that you may encounter a HSAT patient while working in the polysomnography field, you may also have up to, keyword up to 18 questions, which is about 60 points related to HSAT according to the current BRPT registry exam blueprint. So it's very unlikely that you may actually have all 18 questions on HSAT. But you will definitely have questions on this subject, so it's wise to be knowledgeable on the subject. So basically what I'm trying to say is that the portion of the exam that contains HSAT is 18 questions in that portion, but HSAT is just one of the topics under that single portion, if that makes any sense. So it may share a section with um, let me just say arousals or movement or whatever the case may be. So basically what we're saying is that it's possible that you can have all 18 questions on HSAT, or you might only have two. You might only have five. So basically just important to know it, because you just never know what version of the BRPT exam that you're going to get. All right, so indications for portable monitoring. So indications for portable monitoring, what we mean by that is when will we use it? What's going to indicate, okay, well, this patient needs portable monitoring, or this patient needs HSAT or out of center testing. Like what lets us know to give the patient the HSAT advice? So portable monitoring, aka HSAT, for the diagnosis of obstructive sleep apnea should be performed only in conjunction with a comprehensive sleep evaluation. A comprehensive sleep evaluation, not a sleep study, A comprehensive sleep evaluation. When we evaluate patients, we look at their medical history, we ask them questions, we outweigh the risk, we outweigh the likelihood of this patient having OSA, just things like that. So it should only be performed if we have already thoroughly evaluated this patient, and uh, their sleep habits, their medical history, things like that. All right, so clinical evaluations using portable monitoring must be supervised by a practitioner with board certification in sleep medicine or an individual who fulfills the eligibility requirement for the sleep medicine certification examination. So basically, in order to run the clinicals, what the certain sleep facilities do in the daytime, in order to do that using Hsat, it has to be supervised by a doctor that's already certified in sleep medicine, or a doctor, or I think a better word is a medical professional that's eligible to take the sleep medicine certification exam. All right, so in the absence of a comprehensive sleep evaluation, there's no indication for the use of portable monitoring. Let me say that again. If you don't evaluate the patient, if the patient has not had a thorough sleep evaluation, aka assessment, we do not put them on portable monitoring or Hsat. We don't use the device, okay? All right, so when is Hsat used? Portable monitoring, aka Hsat, may be used as an alternative to polysomnography for the diagnosis of OSA in patients with a high pretest probability of moderate to severe OSA. And this is a BRPT question. So we're only going to use portable monitoring or Hsat if the patient is likely to have moderate or to severe OSA. What is moderate OSA? Moderate OSA is when their AHI is 15 to 30. That's moderate. Moderate, mild, same thing. Severe is anything over 30. It's considered severe. Okay, so if they're likely to have a high AHI, if they have a lot of risk factors, we're going to assume that if we gave them a PSG, then they would have either a mild or severe AHI. And this is how we do this. So we have a certain neck circumference in men and a certain neck circumference in women. I'm not saying it right now because you should know it, so I'm just going to give you a moment to fill in the numbers, and then I'm going to review the numbers. Obesity, which means a body mass index of at least a certain amount. If this patient snores, if this patient has excessive daytime sleepiness, if this patient is fatigued, if this patient has diabetes, hypertension, congestive heart failure, or if they have a certain Mallampati score. Okay, if they have a certain Mallampati score, along with all of these other things, then more than likely it's okay for the patient to have a Hsat device at home or a portable monitoring device at home. But if they're likely to have just a mild case of OSA, then that's when we bring them into the lab because it's kind of questionable. But if it's barely questionable whether or not they have it, more than likely we're going to more than likely we can use the Hsat device. All right, so take a moment to fill in these numbers if you haven't already done so, and then I'm going to reveal them. All right, so a neck circumference of 17 inches in men and 16 inches in women. So how many centimeters do you think in men and women? 40 for both. Obesity is defined as a BMI of at least what? 30. A Mallampati of at least what is considered, suggestive of OSA? 4. All right, so we have a Mallampati versus a Friedman score, however you want to say it. I say Friedman. Okay, so at the top we have our Mallampati score. I'm reading from the bottom of the screen. So at the top the top picture, we have the Mallampati score. It was developed to predict, the risk of a difficult endotracheal intubation. That's why it was originally developed. Okay. The patient's oral pharynx is examined with the tongue protruded. Notice how the tongue is sticking out of the mouth. Okay. You will have this on your test. I'm going to ask you, why was the Mallampati score developed? Okay. It was developed to see how hard it was to put a endotracheal tube in this patient. Okay, I'm also going to ask you what is examined with the Mallampati score. We're examining the patient's oral pharynx. Okay, also look at the picture. Class 1, if a patient sticks his or her tongue out and it looks like class 1, they are way, 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 way less likely to have OSA. Okay, because you clearly see clear passage. It's a lot of room for the patient to be able to inhale and exhale, during their sleep or during, wakefulness. We don't see any type of blockage. All right, and class 2 is slightly blocked. So we're kind of getting into the, maybe this patient could have OSA, maybe not. Class 3 is more than likely, they may have a moderate, chance of having OSA, because it's not much room for much air to get in and out through the mouth, at least. And class 4 is just a complete blockage. Like, it's just, of course the patient can still breathe, but it may be difficult at nighttime. They may have episodes where they stop breathing at nighttime. All right, so the bottom picture is what we call a modified Mallampati score. MMP, modified Mallampati score. And it's called the Friedman or Friedman score. Okay, some people say Friedman, some people say Friedman. It is similar to the Mallampati score, but the patient simply opens the mouth without saying ah or without protruding the tongue. So look at the two pictures. The regular Mallampati, you ask the patient to open their mouth and say ah. The modified, you just literally just ask them to open their mouth. And if they stick their tongue out, you ask them to just put their tongue back in. So it's the same thing. The only difference is whether or not the tongue is out. Modified, the tongue stays in. So just make sure you remember that on the test. All right, when is Hsat used? So when will we use it? So we would use portable monitoring for the diagnosis of OSA in patients whose in-lab PSG is not possible. It could be that the patient is immobile, they can't get around. It could be safety reasons. What if this patient would be a danger to the lab techs or to, even to themselves? Or it could be due to critical illness. If the patient is critically ill, then, there's no reason for them to have a PSG. I mean, in my personal opinion, there's no reason for them to have a PSG or Hsat, but, that's just one of the reasons that they listed as to why we might do a Hsat study. If the patient is immobile, if it's safety reasons, or the patient has a critical illness. All right, so portable monitoring, aka Hsat, may also be indicated to monitor the response to non-CPAP treatments for sleep apnea. This is a BRPT question. Someone had this question on their exam. Let me read that again. Portable monitoring may be indicated for what? It may be indicated to monitor the response to non-CPAP treatments for sleep apnea. What are non-CPAP treatments for sleep apnea? If the patient doesn't want CPAP, or the patient is on CPAP and I'm not going to say it didn't work, but let's say that the patient wouldn't use it. I think that's a better way. CPAP wouldn't work out for the patient. What would we do? What are the options? Well, we can have surgery. We can do the oral appliance. We could suggest lifestyle changes like weight loss and things like that. So we give those methods time to work, or at least we give the patient a reasonable amount of time to do those things, and then we would give them send them home with the portable monitoring device to see if it's actually working for their sleep apnea. All right, so I just named some examples of non-CPAP treatment for you. Oral appliance, which is what we talked about earlier. It looks like a clear mouth guard. It kind of looks like what athletes, specifically football players, use when they're on the field. It kind of looks like a mouthpiece. But this, they would actually have to go to a dentist for it. We don't do this at the lab. The physician doesn't do this. The physician will refer the patient. If they want this, they would refer them to a dentist. All right, then we have upper airway surgery, where you see that the tonsils were removed. Think about tonsillectomy. Anything ectomy is the removal of something. So tonsillectomy, the removal of the tonsils. Okay. All right, and then weight loss. Put the patients on a diet, give them a couple months, and then give them the Hsat device and see if it worked. All right, when is Hsat inadvisable? So when will we not use Hsat, aka portable monitoring? So it's not appropriate for the diagnostic evaluation of patients that's suspected of having comorbid sleep disorders. So a comorbid sleep disorder is when a patient could have two different sleep disorders. We wouldn't give a patient a Hsat study if we suspect that they may have, like let's say OSA and periodic limb movements, or if they have OSA and narcolepsy, just things like that. If they have any type of comorbid sleep disorders or conditions, we wouldn't give them the portable monitoring device. All right, portable monitoring is also not appropriate for general screening of asymptomatic populations. What this means is that we do not send a patient with a portable monitoring device if they have no symptoms. Because think about it, in order to send them home with a portable monitoring device, we have to have a comprehensive sleep evaluation. If they don't have any type of symptoms of anything, then why would we send them with it? Like nothing, we can't see anything physically wrong. They're not complaining about their sleep. They don't fit the neck circumference criteria. They don't have a Mallampati 4. I mean, just all the, they don't complain about snoring. If they don't have any type of symptoms, why would we put them on it? Okay, so that's why that makes sense. All right, comorbidity. A comorbid condition is when a patient has one disease or condition that occurs simultaneously, aka at the same time, but usually independent of one another. Okay, so comorbid disorders in the sleep profession will include, but are not limited to, hypertension, diabetes, congestive heart failure, and stroke. Okay, those are comorbid conditions. Two different diseases or conditions, but they're independent of one another. I have both of these, but it's two different things. All right. Other times that we would not use Hsat, aka portable monitoring, is for neonates and infants. We don't use it for those. And like I said, I'm guessing that we don't use it for children or pediatrics either, because we only have Hsat rules for adults. We don't have them for children. So unless they change that, we're going to say that we just don't use it for anyone under the age of 18. All right, we don't have it for hypersomnia workout. What is hypersomnia? Hypersomnia is too much sleep. Think about hyper is excessive. Anything hyper is too much. And we know somnia is sleep, so too much sleep. Parasomnia is like abnormal sleep. Those like abnormal movements or actions we don't want. Like sleepwalking, sleep talking, head banging, all that type of stuff. Seizures. We wouldn't use Hsat for a patient that has seizures. Why? Because some Hsat devices don't even include your brain waves. I mean, it's shocking, but yeah, some of them don't use EEG leads. So that's how we would detect a seizure. That's a main key in detecting a seizure. We don't use it for periodic limb movement. Why does this make sense? It makes sense because we don't hook up anything on the legs with portable monitoring at all. We don't use the leg leads. We don't use it for severe insomnia. Okay, if the patient is less likely to fall asleep in the first place, then why would we even use it? We don't use it for neuromuscular disorders like, Parkinson's, things like that, or hyperventilation. We don't use it for central sleep apnea. Okay, we don't use it for any of these things. All right, so the technology for portable monitors. At a minimum, the portable monitors or the portable monitoring device must record airflow, respiratory, and blood oxygenation. So you need that nasal cannula. Okay, you need the nasal cannula, you need the respiratory belts, and you need the pulse ox. At minimum, that's all you need. Cannula, respiratory belt, pulse ox. Let's go back to the performance slide. This is what I was talking about when I said that, okay, you're not using it for seizures. You don't have to have EEGs when you're using a portable monitoring device. So once again, that's why they make sense. All we really need at minimum, airflow, respiratory, pulse ox. All right, the same type of biosensors used to monitor these parameters for, like, if they were coming for a PSG or a CPAP, it's the same type that's going to be recommended for portable monitoring. Okay, so the same type of thermal nasal airflow that we would use for a PSG or CPAP, that's what we use for portable monitoring. Same type of respiratory belt or respiratory monitor, should I say, that we would be using to detect respiratory effort in PSG, CPAP, we use it for here. Same pulse ox, we use it here. All right, so I created this helpful mnemonic to hopefully help you remember it on the test. Is what you need at minimum for Hsat. You need blood oxygenation, aka pulse ox. You need airflow, and you need respiratory effort. Okay, BAR, BAR, blood oxygenation, airflow, respiratory effort. Now, the AASM also recommends recording heart rate. And I can see that. I would think that would be important. That's what the AASM recommends, okay? But at a minimum, you need BAR, blood, airflow, respiratory. That's the minimum. But they also recommend heart rate as an additional one. And it is on the test, by the way. All right, so these are the types of Hsat, or aka PM studies. So make sure that you remember this, because all of this is on the test as well. Type 1, in lab. I put that in red. That's the only one that we do in lab. The only one. In lab is type 1. It's a sleep study with at least 7 channels. This is the one that we actually hook up the EEGs, we hook up the EOGs, we hook up the EMG, meaning the facial EMG. We're not putting anything on the legs. We do the ECG. And then, of course, our airflow is already recommended. That's our minimum anyway. Airflow and respiratory effort. And our blood oxygenation, aka SaO2 or SpO2. I think most labs will use SpO2. SpO2, blood oxygenation, pulse ox, all that's the same thing. Okay, pulse ox is actually the actual device though that we use. It's like the little finger probe. But SpO2, SaO2 measures our blood oxygenation. So all of this talking about the same thing. All right, type 2 is the exact same as type 1 except for it's unattended. Unattended means that it's not in lab. That means it's at home or it's at the hotel or it's wherever the patient is. If the patient in jail, it's there. Wherever the patient is, that's where it is. It's unattended means that it's not attended by sleep tech or anybody else. You know, it's not attended by a healthcare professional. It's just patient at home, you know. Type 3, again, is full unattended, but it has at least 4 channels. Okay, so it has our basic channels that we need, which is our pulse ox, our cannula, and our respiratory belts, but it also has your heart rate. So it has bar plus heart rate. So type 3 is kind of like what the AASM would at least recommend, because it has your minimum 3 channels you need plus your heart rate. So that's type 3. Type 4 is at least 3 channels, which is bar. It has bar and it has the ability to quantify the RDI or the AHI. RDI meaning respiratory disturbance index, AHI meaning apnea hypopnea index. All right, so the methodology for portable monitoring. Okay, portable monitoring testing should be performed under the auspices, like under the this is why we would do it like this, is under the direction of the AASM accredited comprehensive sleep medicine program, with policies and procedures for sensor application, for scoring and interpretation of portable monitoring. Okay, so we're gonna do it like under their guidelines. Basically, we're doing it under AASM guidelines for like what sensors to use, how we score it, things like that. All right, a quality performance improvement program for portable monitoring, including interscore reliability, must be in place to assure accuracy and reliability. Let me say it again. We have to have some type of interscore reliability in order to make sure that our scoring is accurate and reliable. Okay. Portable monitoring devices must allow for the display of raw data. Must allow for the display of raw data. I recently had a student that she had a test on her exam, and it was saying something about, well, the patient had a study and, it didn't allow for raw data. Well, under that case, you would just do the study again. You have to, the key word is it must. If raw data is not available, then you have to make sure that it is available. So you would have to just repeat that Hsat study. Send them home with it again. All right, so it must allow for the display of raw data for manual scoring or editing of automated scoring by a trained and qualified sleep technician or technologist. The BRPC exam may give you a critical thinking question based on this statement, which is what I just said. Evaluation of portable monitoring data must include a review of the raw data by a board-certified sleep specialist. Let me say it again, evaluation. So who's going to be looking at it? Okay. The data must include a review of the raw data by a board-certified sleep specialist or somebody who is eligible to take the sleep medicine board certification. Scoring criteria should be consistent with the current published AASM standards for scoring of hypopneas and apneas. Due to the known rate of false negative portable monitoring tests, in laboratory polysomnography should be performed in cases where portable monitoring is technically inadequate or it fails to establish the diagnosis of OSA in patients with a high pretest probability. So what do you mean by that? That means we're going to, if we gave the patient an Hsat and we feel like the results were falsely negative, then we would bring them in for a PSG. Also, if the patient, let's say the patient's neck circumference is a female and her neck circumference is 22 inches, okay? We only need 16 for women. Her neck circumference is 22 inches. Let's say that her Mallampati score is 4. Let's say that she snores. Let's say that her BMI is 43. she would have a high pre-test probability of having OSA. We haven't had the test yet, but we're predicting that you're probably going to have, a high chance of having OSA. So in her case, let's say we gave her a Hsat study, aka portable monitoring device. She went home with it, and they said that it was, that there was no, she didn't qualify for having obstructive sleep apnea. Then we would bring her in for a PSG just to make sure that these results are correct, because it's highly unlikely that she doesn't have OSA. So that's what we mean by that. All right, so what happens after you have your Hsat study? What happens then? Okay, so then you're going to have a follow-up visit with a physician or other appropriately trained and supervised healthcare provider. And that's going to be performed on all patients undergoing portable monitoring to discuss the results of the test. After you have it, you're going to have a follow-up with the healthcare provider. Okay, you're going to have a follow-up with either a physician or some type of healthcare provider to discuss your results. All right, so here is our self-study question section. Make sure that you do note cards on this or just go over and over again. We were going to do a Kahoot, in the classroom, but since we all are probably not going to be logging on at the same time, there's no need to do a Kahoot because we would have to do that simultaneously. So I just posted the questions here. All right. Also, once again, any questions that I read, you are more than likely to see them very, very soon. Which of the following clinical findings is most predictive of the OSA? Of OSA, should I say? Which of the following clinical findings are most predictive of OSA? Neck circumference of 44. Why? Because according to the BRPT, many patients with OSA are not obese. Okay, many patients with OSA are not obese. While body mass index and Mallampati classification can certainly be contributing factors to sleep apnea, is the neck circumference that is most predictive of having OSA. Your neck circumference. Your neck circumference is going to be the telltale sign, more than likely, of whether or not the patient has OSA. Patients with a neck circumference of greater than 48 centimeters have a 20-fold increased risk of having OSA. Okay. And as far as the Epworth Sleepiness Scale, it's possible to have a very high ESS and have a PSG that's negative for, OSA. So out of these, even though that Mallampati is kind of high, they could possibly have it. The BMI is very high. They could possibly have it. I mean, all of these are contributing factors. All of these will indicate that a patient may have OSA. But the key word here is most predictive. So the most predictive will be the neck circumference. All right, so according to the ASM guidelines, portable monitoring is appropriate to do what? Is it to monitor a patient's response to oral appliance therapy? Is it to diagnose hyperventilation syndrome? Is it to screen patients with a low probability of OSA? Or is it to assess patients with low baseline oxygen saturation? Which one would it be? Monitor a patient's response to oral appliance therapy. Why does this make sense? Because we just read on a previous slide that it's used to monitor a patient's response to non-CPAP treatment for sleep apnea. Oral appliance is considered a non-CPAP treatment for obstructive sleep apnea. We just went over that. We can have, like, non-CPAP treatments for sleep apnea include oral appliance, it includes the surgery, and it includes weight loss. All right, so according to the ASM guidelines, portable monitoring is appropriate for monitoring a patient's response to oral appliance therapy. Other acceptable criteria for the use of portable monitoring include a high pretest probability Moderate to severe OSA, we already went over that. Cases where a full PSG is not possible due to the patient not being mobile, if safety is a concern, or if the patient is critically ill, or also, which is what I just said, monitoring the response to non-CPAP treatment of OSA, which is what the answer choice right here is. All right, so true or false? A registered sleep technologist must perform any in-lab Hsat study. Do you think that is true or false? It is false. An experienced sleep tech must perform it. Experienced, not registered. You can be a registered tech and have no clue of how to, explain to the patient about a portable monitoring study, aka Hsat study. You may not have the experience. You don't know how to actually explain the test to them and answer their questions that they may have. So it has nothing to do with you being registered, as long as you're experienced. All right, so they must either perform the application themselves or they must directly educate the patient on how to correctly apply these sensors. Okay. According to the recommended, keyword recommended guidelines, unattended portable monitoring can be used as an alternative to in-lab testing when what? Okay. When comorbid disease processes make in-lab studies difficult, or could it be that there is a high probability of moderate to severe OSA without comorbid conditions, or differentiating RBD from OSA, or if the patient is unable to complete a comprehensive sleep evaluation? According to the recommended guidelines, unattended portable monitoring can be used as an alternative to having an in-lab study when what? When there's a high probability of moderate to severe OSA without comorbid conditions. Alrighty, so at minimum, portable monitoring must record what? Check all that apply. At minimum. Now I'll give you a hint, it's 3. BAR, B-A-R, blood, airflow, respiratory. It's not in the same order because I want you to remember it no matter how it's thrown out there at you. But the AASM also recommends us recording heart rate. Oh, I'm sorry. Didn't know that was the next question. The AASM also recommends recording of the following. Of course, I just gave it to you, heart rate. All right, so for monitoring respiratory effort, it is recommended to use what? Is it a single or dual PVDF belt? Is it a single or dual thoracoabdominal rib belt? Is it a single or dual piezo belt, or is it all of these? What's the recommended for monitoring respiratory effort? It's the single or dual thoracoabdominal rib belts. RIP. Inductance plasmography. Respiratory inductance plasmography is recommended. Inductance plasmography. Sometimes they might say respiratory inductance plasmography. Sometimes they just might say inductance plasmography. Make sure you know it either way, that's what's recommended. What are the 7 channels used in portable monitoring testing? Check all that apply. And the answer is everything but snore. We don't use snore. These are the 7. If we were using 7 channels, this is what we would do. All right, which Mallampati score is suggestive of OSA? Make sure that you are familiar with your Roman numerals. 4. Initial screening of portable monitoring should be performed by all of the following except what? Initial screening, which is our evaluation, things like that. It should be done by who? By all of the following except who? Our PSGTs do not do the initial screening. The initial screening comes from a physician. A dentist is still a physician. Physician is the person that does the initial screening. Is it possible to score hypopneas based on arousals? Do you think it's possible to score in a hypopnea based on arousals? Yes, but only if sleep is recorded. Why this makes sense is because we know that if we're doing a PSG or a CPAP study, we can still score a hypopnea based on an arousal, right? We don't necessarily have to have the 3% DSAT. It's a criteria, but if we don't have a 3% DSAT, then as long as the event was associated with an arousal, we can still score it as a hypopnea, as long as we still, had our other criteria, which is at least 10%, 10-second duration, and 30% drop in peak signal. Okay. True or false? It is optional to report the occurrence of snoring and body position during Hsat. True or false? It is optional to report the occurrence of snoring and body position during Hsat. True, it's optional. Think about this. We also don't have to record, we don't have to score or anything like that. Snoring is optional. So if we don't have to score it, we don't have to record it either. So we don't have to do snoring and body position for a regular PSG or CPAP. So the same rules would apply for Hsat. You don't have to do that. For identification of RE, aka respiratory events, based on a home sleep test, for a diagnostic study, it is recommended, keyword recommended, to use all of the following except what? For identification of respiratory events based on a Hsat study, is recommended to do what? To use all of the following except what? PVDF sum. Why this makes sense? Because we just went over the different types of rip belts that we would use. And we know that it wouldn't be D because we know that respiratory inductance plasmography is a recommended channel. Okay, it's recommended. It's also recommended as far as our airflow channels to use an oral nasal thermal airflow sensor or nasal pressure transducer. So we will follow all of the same recommended guidelines that we would do for PSG or a CPAP. Which of the following would be monitored during Hsat the most? Which of the following would be monitored the most? Should be monitored the most, should I say? Airflow. Airflow. A doesn't make sense because you don't necessarily need the head leads. You don't need the eyes, the E's, or you don't need the head leads, the eye leads, or the chin leads, because you can have a Hsat study without those leads at all. Also, B doesn't make sense because you don't need that as well. You don't need the EKG pads. I mean, the ASM recommends that you monitor heart rate, but you don't have to. At minimum, you need bar. So blood oxygenation, which is your SpO2. You need airflow and you need respiratory. Okay, but the question asks which should be monitored the most. The most should be airflow. Think about it, because we are monitoring for obstructive sleep apnea. Okay, you don't need a drop in DSAT to have an apnea. More than likely, you're going to see one, but obstructive apnea does not have to have a desaturation. So that's why this is the only answer that makes sense. So just use your critical thinking when you are taking your test. All right, so as always, read your ASM scoring manual. There'll be a free portion on the exam containing information straight from the manual. No cards on this PowerPoint self-study questions are not required, but they are strongly suggested. I strongly suggest that you do so. Okay. Once again, if you have any questions, please do not hesitate to reach out to me. Okay.